Thomas Varghese Achan, may I request you to start with a word of prayer, Achan.
Shall we pray? നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം, ഒരുമിച്ച് പ്രാർത്ഥിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധ സ്തുതി ആദ്യമേക്കും തന്നെ. ആമേൻ. സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, ഞങ്ങളങ്ങേ സ്തുതിക്കുന്നു, സ്തോത്രം അർപ്പിക്കുന്നു. 2023 ഫെബ്രുവരിയുടെ അവസാന വ്യാഴാഴ്ച തിരിഞ്ഞു നോക്കുമ്പോൾ കഴിഞ്ഞ 2 മാസക്കാലവും ഞങ്ങളെ നടത്തി. ഓരോ വ്യാഴാഴ്ചയും ഞങ്ങൾക്കിതുപോലെ ഇവിടെ കൂടുവാനും പുതിയ പുതിയ കാര്യങ്ങൾ കേൾക്കുവാനും അത് ഗ്രഹിപ്പാനും അത് ഞങ്ങളുടെ പ്രൊഫഷണൽ ലൈഫിൽ ഇൻട്രൊഡ്യൂസ് ചെയ്യുവാനും ദൈവം സഹായിച്ചതോർത്ത് നന്ദിയും സ്തോത്രം അർപ്പിക്കട്ടെ. ഇന്ന് ഉപയോഗിക്കുവാൻ പോകുന്നതായിട്ടുള്ള റിസോഴ്സ് പേഴ്സൺസിനായി നന്ദി. അവർ പ്രിപ്പയർ ചെയ്തു, പഠിച്ചു. എന്നാൽ അത് കേൾക്കുന്നവർക്കൊക്കെ ഒരനുഗ്രഹമായി തീരുവാൻ ദൈവം അവരോട് കൂടെ ഇരുന്ന് അവരെ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. അതിലുപരിയായി വന്നിരിക്കുന്നവരെയും വരാൻ ആഗ്രഹിക്കുന്നവരെല്ലാവരും എത്രയും വേഗം കൂട്ടിക്കൊണ്ടുവരികയും ഞങ്ങൾക്കും ഞങ്ങളുടെ ഇൻസ്റ്റിറ്റ്യൂഷനും മുൻപോട്ടുള്ള ഞങ്ങളുടെ ജീവിതത്തിനും അതൊരനുഗ്രഹമാക്കി തീർക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. പ്രാർത്ഥനഘട്ടനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Thank you, Achan. Today the title doesn't look very rosy in the morning. So double trouble. Microvascular complications of diabetes. To explain more and to introduce our presenters, we have Assistant Professor of Ophthalmology, Dr. Leena Mariyam Varghese. Let's welcome her.
Good morning all. A warm welcome from the Department of Ophthalm. Today we'll be talking about diabetic retinopathy and diabetic mononeuritis. We took up this topic because, as we all know, diabetes is very common in actually worldwide. We'll come to the census later. So we'll first start off with the topic. A case presentation by Dr. Jayalakshmi. She's a senior PG, which is followed by discussion by Dr. Sandhra. She's a junior PG.
Good morning to all. Presenting the case of 68-year-old male patient presented with complaints of double vision since 6 weeks. He noticed double vision 6 weeks back while waking up in the morning. Double vision was present on looking straight and looking towards left side initially. At present, it is only on looking towards left side. Double vision was maximum when looking towards left side from the beginning, more for distant than for near vision. It was not present on right gaze. And double vision decreased on turning face towards left side. Double vision was absent on closing one eye. He could see 2 images side by side, which was horizontally separated, and the distance between 2 images increased when looking more towards the left side. He had no worsening of symptoms towards evening. He consulted a nearby hospital after 3 days and was advised a detailed evaluation and was referred to neurology department of BCMCH here. And after neurology evaluation, the patient was referred to ophthalmology department. Then no blurring of vision, pain or trauma, no deviation of angle of mouth, dribbling of saliva or difficulty in eye closure, no redness, bulging of eye, no loss of consciousness, vomiting, headache, pain, neck fever, recent vaccination, no weakness of one side of body or limbs or other neurological deficits, no tinnitus, vertigo, fullness in the ear, earache or hearing loss, no difficulty in swallowing food, no scalp tenderness or jaw claudication. Past history, no similar illness in the past. Is a known case of type 2 diabetes mellitus since past 27 years on insulin. It was uncontrolled at the time of presentation, and GRBA was 300 milligram per deciliter during the time of initial evaluation. No history of hypertension, dyslipidemia. History of right foot ulcer, status post debridement 8 months back. No ocular procedure, surgery, trauma. Personal history was normal. General examination and vitals were within normal limits. Then systemic examination, cardiovascular system, respiratory system and gastrointestinal system examination was found to be normal. Moving on to cranial examination of nervous system. Higher mental function was normal. Olfactory nerve, sense of smell was normal. Nerve, optic, oculomotor, trochlear and abducent nerves will be discussed in detail in ocular examination. Then trigeminal nerve, sensory, motor and reflexes were found to be normal bilaterally. Facial nerve also, motor and sensory components normal, auditory, glossopharyngeal, vagus, spinal accessory and hypoglossal nerve examination were also found to be normal. Tone, bulk, power and reflexes were normal bilaterally. Sensory system normal, no cerebellar signs and no signs of meningeal irritation. Now moving on to detailed ocular examination. First of all, we'll look for the posture, head posture, and then the forehead, then facial symmetry, etc. So in this patient at the time of examination at 6th week of double vision, the head posture was erect and the forehead wrinkling was normal. Then face was symmetrical. Then Hirschberg test was orthophoric. This is a test that is done to check the alignment of eyeballs. So orthophoric means it was normally aligned. If there was any deviation, there was no deviation in the alignment of visual axis. Then extraocular movements. There are 6 extraocular muscles, and all the function or the action of all the 6 extraocular muscles of both eye can be assessed in this 9 gaze positions. So so in this figure, the patient is looking straight forwards. So there is no deviation or alignment is correct. Now, here the patient is looking upwards at this elevation. This is called as depression. Here the patient is looking towards right upper position. Then this is dextro elevation, dextroversion, dextro depression. And this is patient is looking towards the left upper position, then to left side and left downwards. So in the figure we can see when the patient is looking towards right side, the eyeball is moving completely laterally. But in the figure, in this figure we can see the eyeball is not moving completely laterally. So that means there is a limitation of movement in the left side. So we can see there is a grade for limitation. So grading is done based on the movement. So here we can see the eyeball is not shifting from midline. So in this figure, the eyeball completely moves towards the lateral position, whereas here it is not shifting from midline. So there is grade for limitation. So extraocular movement examination was full, free and painless in all directions in right eye, but there is a abduction limitation of grade 4 in left eye. Then vision, unaided vision was 6/12 parts in right eye and 6/9 parts in left eye. Then aided vision was 6/12 and 6/9. So normal vision will be 6/6. Here it is 6/12 and 6/9. That means there is a little lesser than the normal values. Then color vision was found to be normal in both eyes. Then moving on to examination of periorbital area, lids, conjunctiva, sclera, cornea and anterior chamber was normal in both the eyes. Iris, the color and pattern of iris was normal. Pupil of both eyes were 3 mm, undilated, round, regular, no relative afferent pupillary defect. Then direct and consensual reflexes were hazy, the media is hazy. Optic disc was oval in shape with a cup disc. This is the cup disc ratio of 0.4. Then neuroretinal rim was healthy and the margins of the optic disc were clear, well defined. There was no papilledema. Then vessels were normal with AV ratio 2:3. Here we can see dot and blot hemorrhages in the fundus. Then foveal reflex was absent. In the left eye also the findings were same. Optic disc was oval in shape with the cup disc ratio of 0.4. Then disc margins were clear, no papilledema. Vessels were normal with AV ratio 2:3. And here also we can see as the media was hazy, dot and blot hemorrhages are not very clear in this picture. Here also there are hemorrhages, retinal hemorrhages. So this is shows moderate NPDR, a moderate non-proliferative diabetic retinopathy. Moving on to investigations, OCT macula was taken. So it was found to be normal. This is the diagram showing OCT macula. So if there was macular edema, then this depression won't be there. There will be an elevation, but both time OCT macula was found to be normal. Then this is the figure showing diplopia charting of this patient. So diplopia charting is done in order to correctly identify the position, if it is vertical, horizontal, etc. So the patient is, diplopia charting is done basically in a dark room. Then we give a pair of glasses to the patient with the red color will be on the right side and green color will be on the left eye. And then in a dark room, the examiner is standing behind, and a source of light is thrown onto the wall or on the screen in front, and the patient is asked to interpret the image that he or she sees. So if the patient can see, if the patient sees one single image, then it will be like this, both red and green will be fused together. But if the patient has double vision, then we can see there will be a separation between the red and green images. So here we can see in the right gaze, and when the patient is looking straight, only one image is formed. But when the patient is looking towards the left side, there is a separation between the two images. So we can say that there is double vision on looking towards the left side, and this is a horizontal double vision, because the two images are seen horizontally separated. If there was vertical component, then it would have been, the images would be formed up or downwards. Okay. Moving on to diagnosis. This is a case of isolated left lateral rectus palsy, probably diabetic mononeuropathy, and moderate non-proliferative diabetic retinopathy and immature senile cataract of both eyes. Moving on to investigations. Medicine consultation was sought. And then blood sugar levels were 300 milligram per deciliter. Then lipid profile was done, and blood pressure was taken. Lipid profile was within normal limits, and blood pressure also was 140/90. Then neurology consultation was sought, and MRI brain was taken, which was found to be normal. So moving on to management of the patient. This is an isolated diabetic mononeuritis. So first and most important management is the control of blood sugars, and the patient was reviewed after every 4 weeks, and within 3 months itself the patient completely recovered. Then after 6 months, the patient was asked to come for diabetic retinopathy evaluation and for cataract evaluation. Now, this is the figure after 3 months. So here in the figure we can see the left side eyeball is moving completely towards laterally. That means that the lateral rectus palsy was resolved. Now, moving on to causes of diplopia. So if a patient presents with double vision, first of all we have to identify if it is monocular double vision or if it is binocular double vision. So we'll ask the patient to close one eye. If the patient still complains of double vision on closing one eye, that means it is a monocular diplopia. So the causes for monocular diplopia can be refractive errors, high refractive errors, then cataract, dislocation of the lens. So it can also cause double vision. Then corneal distortion, corneal scarring, keratoconus, then vitreous abnormalities, etc. Then binocular double vision, there are mainly 3 causes. It can be due to neuromuscular junction problems, neuronal problems, and extraocular muscle restriction or entrapment. The most common one is neuronal, that is nerve paralysis, etc. So neuronal causes, we'll have to ask the patient if he or she is seeing the images, if they are seeing it horizontally separated or if there is a vertical component to it. If there is only horizontal diplopia, then we will have to think of lateral rectus palsy, 6th nerve, abducens nerve palsy. Then if there is horizontal or vertical component, then it can be divided into, it can be due to oculomotor nerve and trochlear nerve palsy. Then Graves' ophthalmopathy can also cause double vision. Then causes for abducens nerve palsy, most common causes ischemic or vascular causes like diabetes mellitus, hypertension, dyslipidemia, etc. Then other causes can be aneurysm, tumor, trauma, etc. Then meningioma, schwannoma, etc. can cause sixth nerve palsy. Isolated sixth nerve palsy, posterior draining carotid cavernous fistula is a rare cause for isolated sixth nerve palsy. Thank you.
Good morning, all. Myself, Sandhra Rose, first year PG resident. As we all know, diabetes mellitus has become a global pandemic, and its microvascular complications has debilitating effects on different systems. One such microvascular complication is diabetic retinopathy. Due to diabetic retinopathy, about 40 to 45% of diabetics are at risk of vision impairment. So its screening and diagnosis hold a great importance in the present health scenario. So today I will be discussing about diabetic retinopathy under these headings and also about diabetic mononeuropathy. Firstly, diabetic retinopathy. Its definition, it refers to a microvascular disorder resulting in retinal changes and damage to retinal blood vessels seen in patients with diabetes mellitus. And its risk factors, the most important risk factor is duration of diabetes. Longer the duration, higher the risk for retinopathy. And second one is poor control of diabetes. As per DCCT and UKPDS studies, strict blood glucose control, when it is implemented early, it can prevent or delay the development or progression of diabetic retinopathy. The other risk factors are pregnancy, hypertension, nephropathy, hyperlipidemia, smoking, obesity, and anemia. Coming to pathogenesis, the chronic hyperglycemia leads to microangiopathy. And the microvascular changes like basement membrane thickening, capillary endothelial damage, and loss of capillary pericytes leads to breakdown of blood-retinal barrier. And as a result, there will be leakage and edema in retina. And the other microvascular changes like deformation of RBC and Rowley formation and increased thickness of platelets, increased viscosity, that leads to microvascular occlusions, which results in retinal ischemia. And to overcome this, there is increased production of pro-angiogenic factors like VEGF, and this results in neovascularization at later stages of diabetic retinopathy. Next is clinical manifestations. Many times, diabetic retinopathy is asymptomatic, and its other symptoms are floaters, blurred or distorted vision when it affects macula, or partial or total loss of vision if there is any vitreous hemorrhage or retinal detachment. Now coming to the fundoscopic findings. Firstly, the microaneurysms. They are the earliest sign of diabetic retinopathy. They are focal dilatation of capillary wall due to absence of pericytes, and they develop in the inner capillary plexus seen in the ganglion cell layer. You can appreciate it well in this fundus fluorescein angiography, where you can see the hyperfluorescent spots in the posterior fundus. Here, these hyperfluorescent spots are the microaneurysms. Next is retinal hemorrhages. Retinal nerve fiber layer hemorrhages. They are known as flame-shaped hemorrhages. They arise from the large superficial precapillary arterioles. And these are the flame-shaped hemorrhages. They assume this characteristic shape due to the alignment of retinal nerve fiber layers. Next is intraretinal hemorrhages. They are known as dot and blot hemorrhages. They arise from the venous end of capillaries in the inner nuclear and outer plexiform layers respectively. You can see it is not very clear, I know. The dot hemorrhages are the larger ones are the blot hemorrhages. Exudates, they are the waxy yellow lesions. These waxy yellow lesions occur due to retinal edema. They are arranged in clumps and or rings surrounding leaking microaneurysms, and they are composed of lipoprotein and lipid-filled macrophages, and they are located within the outer plexiform layer. Next is diabetic macular edema. They are retinal thickening with or without exudates due to capillary leakage and edema, and it can be focal or diffuse. It is the commonest cause of visual loss in diabetic retinopathy. And focal maculopathy, that is a well circumscribed retinal thickening, and it is associated with complete or incomplete rings of exudates. Next is diffuse maculopathy. You can diffuse retinal thickening, and it is associated with cystoid changes. Now, what is clinically significant macular edema? That is CSME. If there is any retinal thickening or hard exudates within 500 micrometer of the center of macula, or retinal thickening which is of one disc area or larger, any part of which is within the diameter of within one disc diameter of the from the center of macula. Next is cotton wool spots. These are small fluffy whitish superficial lesions that obscure the underlying blood vessels, and these are accumulations of neuronal debris within the nerve fiber layer. Coming to venous changes in diabetic retinopathy, it can be generalized dilatation or tortuosity, or venous looping like this, or venous beading like this, or there can be sausage-like segmentation like this. Coming to intraretinal microvascular abnormalities, they are fine, irregular red intraretinal lines that run from arterioles to venules without crossing major blood vessels. These are arteriolar venular shunts that run from retinal arterioles to venules bypassing the capillary bed, and they are seen adjacent to areas of marked capillary hypoperfusion. Then proliferative retinopathy. These are characterized by neovascularization, and 1/4 of retina must be non-perfused before proliferative diabetic retinopathy develops. Different signs of that is new vessels at the disc. These are neovascularization on or within one disc diameter of optic nerve head. Next is new vessels elsewhere. That is neovascularization further away from the disc. And also new vessels on the iris, which is known as rubeosis iridis, and it has high likelihood of progression to neovascular glaucoma. Coming to classification, we divide diabetic retinopathy into non-proliferative and proliferative diabetic retinopathy. In non-proliferative diabetic retinopathy, in very mild NPDR, there is microaneurysms only, and in mild NPDR, any or all of microaneurysms, retinal hemorrhages, exudates, or cotton wool spots. And in moderate NPDR, there is severe retinal hemorrhages in 1 to 3 quadrants, or mild IRMA, or significant venous bleeding in not more than 1 quadrant. And in severe NPDR, we follow the 4 to 1 rule. That is severe retinal hemorrhages in all 4 quadrants, or significant venous bleeding in 2 or more quadrants, or moderate IRMA in 1 or more quadrants. And in very severe NPDR, there is 2 or more of the criteria for severe. Next is proliferative diabetic retinopathy. In mild to moderate PDR, there is new vessels on the disc less than 1/3 of the disc area, and new vessels elsewhere less than 1/2 of the disc area. And high risk PDR is when this NVD is more than 1/3 of the disc area, or any NVD with vitreous or preretinal hemorrhage, and NVE more than half disc area with vitreous or preretinal hemorrhage. And advanced diabetic eye disease is when there is preretinal or intraocular hemorrhage or tractional retinal detachment and rubeosis iris. Coming to the management, the mainstay of treatment is screening. And in type 1 diabetes, we have to do the first retinal examination within 3 to 5 years after diagnosis, and in type 2 diabetes at the time of diagnosis itself. And if there is any changes or abnormalities, regular follow-up has to be done according to the stage. If it is no diabetic retinopathy or very mild NPDR, yearly review has to be done. Or if it is mild NPDR, 6 to 12 months review. And in moderate NPDR, 6 months review. And in severe, 4-month review is needed. And in very severe NPDR, 2 to 3 months review is needed. And if there is any maculopathy or proliferative diabetic retinopathy and advanced diabetic eye disease, we need immediate treatment. Coming to the treatment, we have medical management, that is by intravitreal anti-VEGF drugs like bevacizumab and ranibizumab, and intravitreal steroids like triamcinolone and dexamethasone, and laser treatment in severe NPDR or proliferative diabetic retinopathy, we consider scatter panretinal photocoagulation. And if there is diabetic macular edema, we do focal or grid laser. And surgical management in if there is diabetic macular edema or advanced PDR with retinal detachment or vitreous hemorrhage, we have to consider pars plana vitrectomy. Coming to diabetic mononeuropathy, diabetic cranial mononeuropathy, which is sometimes called as ischemic mononeuropathy, it most commonly occurs in those nerves which supply extraocular muscles. And diabetes as the cause of cranial nerve palsy is considered only after ruling out all other causes satisfactorily. With diabetes mellitus, there is a 10-fold increase in risk for ophthalmoplegia, and it is more in type 2 diabetes than type 1 diabetes. And 1% of patients with diabetes mellitus, they develop mononeuropathies. And the most common nerves affected is third nerve, followed by sixth nerve, very rarely fourth nerve. And the combination of nerve involvement may be there, that is mononeuritis multiplex, and it is usually unilateral, bilateral rarely. And it is, there is associated atherosclerosis, retinopathy, nephropathy is usually present. Coming to pathogenesis, hyperglycemia induced damage to nerve cells, or other mechanism is neuronal ischemic change due to damage to vasa nervosum, also inflammation and immune reaction. When to consider diabetic mononeuropathy, the presumptive diagnosis is based on the absence of other neurological signs and symptoms, and if there is no new findings during follow-up, or spontaneous recovery usually occur within 4 months, and other causes are reasonably excluded. Coming to diabetic oculomotor palsy, the classical presentation is acute onset diplopia with profound ptosis, and there will be pupillary sparing. That is, fibers controlling the pupillary reflex are superficial, and they are supplied by in this picture you can see the pupillary fibers are superficial, and they are supplied by pile plexus, while inner fibers are supplied by vasa nervosum, and thus pupillary fibers are spared from diabetic ischemia induced injury. There is also down and out eyeball and restriction of adduction, elevation and depression, and it may vary in isolated superior or inferior division involvement. Diabetic abducens palsy, it is reported as most common diabetic mononeuropathy in some studies, and it usually presents as horizontal diplopia. And you can see in this picture there is esotropia in primary gaze, and there is restriction of abduction, and accompanying hypertension and metabolic syndrome are additional risk factors for diabetic sixth nerve palsy. And isolated fourth nerve palsy is very rare in diabetic mononeuropathy, and it usually occurs in combination with other cranial nerve palsies. Coming to treatment, observation is mainstay of management. During that, we can consider monocular occlusion or prismatic correction of diplopia. Up to 90% recover spontaneously, and in young children, they are treated with alternate patching to prevent amblyopia. And surgery is considered only when adequate time has been allowed for maximal spontaneous improvement, typically at least 6 to 12 months from onset. Thank you.
So thank you, Sandra and Jayalakshmi, for those wonderful presentations. Now, as to why we took up this topic, as we all know, there are about 422 million people worldwide having diabetes, of which 77 million people are in India. And it is expected to rise to over 134 million by 2045. So this is like 1 in 5 individuals have diabetes. So it is very important that we need to know all the complications that can arise due to diabetes, especially when it comes to ophthalmology, it is our diabetic retinopathy and mononeuritis, which is usually seen. In a study conducted in 2022, it was published in Lancet Global Health, they found out that the prevalence of diabetic retinopathy in non-diabetics is around 15.5%, and 4% had vision-threatening diabetic retinopathy. And they estimated that there are about 3 million people, more than 40 years in India, who live with vision-threatening diabetic retinopathy and are at risk of vision loss. So it is our aim to find out these vision-threatening diabetic retinopathy patients as early as possible and treat them. So that is why we need regular screening for the diabetic retinopathy patients. Now, I'm sure all of you have understood what both of them taught you. Do we have PGs and residents here? Can the PGs and interns raise their hands? I just need to know how many of you are here. Yeah, not ophthalm. Yeah. Okay, so many. I just have few questions just to know whether you all understood what we have been telling you. Very simple questions. The topic itself is very simple. There's nothing that you do not know. I just want you all to go back home with these messages. So, when to check for diabetic retinopathy? Is it at the time of diagnosis in type 1 diabetes, 5 to 10 years after diagnosis in type 2 diabetes, not required at all if sugars are controlled, at time of diagnosis in type 2 diabetes? Can you just answer? It's very simple. Very good. So it has to be done at the time of diagnosis in type 2 diabetes. Now, how would a patient with diabetic retinopathy present to us? Can the patient be asymptomatic? Will they always present with blurred vision, floaters, or all of the above? All of the above, exactly. Now, this is the worst part in diabetic retinopathy. They can actually be asymptomatic. So the patients who come to us, they are not really bothered as to whether, the screening or this test is required for them. They are least interested because their vision is almost always not affected. Among these, who do you think will have decreased vision? A patient with mild NPDR, PDR without macular edema or hemorrhage, mild NPDR with macular edema? With macular edema, exactly. Now the problem here is we have a patient with PDR without any visual loss. You have this patient coming to you, he'll be perfectly fine. But this is the patient who's going to develop vitreous hemorrhage later on. It might be within a month or so. So it's very difficult for us to explain to the patient, see, you are having this vision-threatening diabetic retinopathy. So what helps us is this fundus fluorescein angiography and fundus photo. When they see those huge new vessels, at least that will scare them. Because we need to get these patients early in advance so that we can treat them with lasers and protect them. So a PDR patient having good vision is actually dangerous. Now, how do you follow up a patient in diabetic retinopathy? Do you think it's required only if diabetic retinopathy is present? And if diabetic retinopathy is present, if whatever be the stage, you need to review the patient only after 6 months. If there's no diabetic retinopathy, you need an annual DR checkup, and only when the patient has decreased vision. Exactly. So even if there is no diabetic retinopathy, it's always safe to have an annual DR checkup. just what I told before, because we need to catch hold of these vision-threatening diabetic retinopathy patients as early as possible. Now, based on the stage, the review changes. That is why I've said that it is not always 6 months that you have to check for diabetic retinopathy. When it is PDR or severe NPDR, you need to see them as early as possible. Do you think diabetic retinopathy changes are reversible? Yes? Actually, no. Only very early diabetic retinopathy changes, such as microaneurysms, are said to be reversible. That is if your sugars are controlled, but all the other changes are not reversible. So that is why you need to see the patient as early as possible. We need to know whether this patient has diabetic retinopathy or not, because the changes are reversible. Sorry, irreversible. Which is the most common nerve affected in diabetic mononeuritis? Third nerve. It is third, followed by sixth, followed by fourth. In diabetic third nerve palsy, there are 2 PGs there, no? Ptosis is absent, pupil is spared, pupil is involved, eye is rotated upwards and out. Exactly. You have pupil sparing third nerve palsy. You understood why, right? The pathogenesis was explained before. Because the pupillary fibers are in the periphery. Treatment of diabetic mononeuritis, you give diabetic control with conservative management. You can give prisms, squint surgery in case of severe diplopia, all of the above, A and B. One more PG is there, right? Oh, okay. Thank God I have the correct number of questions. Sorry? No, actually you do not do squint surgery in the case of diabetic mononeuritis, because you almost always expect improvement. So if you go and do a surgery or operate on the extraocular muscle, you cannot change it back. So if this patient has exotropia, you go and do surgery, later on this patient will have esotropia. So you do not do squint surgery in a patient with mononeuritis, because almost always, almost 100% or 99% of the time, these patients improve with DM control. So you wait at least for 6 months. These patients improve very fast. And prisms are given only for the temporary improvement to avoid diplopia. You can also give occlusions to the patient if the patient has severe diplopia. Okay? It's just a general question. Say you have a 58-year-old obese chronic smoker who has diabetes, hypertension, and dyslipidemia for past 10 years. He comes to you saying that I had gone for a recent diabetic retinopathy checkup, and the ophthalmologist told me I have diabetic retinopathy. As his physician, what will be your advice to prevent progression of his diabetic retinopathy? Any medicine PG can answer? They are usually your patients. They come to you for advice. We just tell them, they usually don't listen to us. So what would you do, or what would you tell the patient? Yeah. You think only that is enough? You have to make sure everything else is under control. No, because he has so many risk factors. Practically, he has all the risk factors that lead to progression of diabetic retinopathy. So strict diabetic control, yes, that is the most important. But you also have to make sure that his BMI reduces. He does regular exercises. He stops smoking. His hypertension is under control. His dyslipidemia is under control. Okay, so you have to make sure not only diabetes, but all the risk factors are also under control, so that you make sure that there is no progression of diabetic retinopathy. Okay. So it's good to know that so many of you have understood so much from our topic. If we have any doubts or discussion regarding the case, I can ask my PGs to come back. It would be nice if any of the sirs could ask our PGs something. Yes, ma'am. Yes, ma'am.
I mean, under Chaitanya, Priya is doing retinal injection.
Yes, ma'am.
By the grace of God, it is like that. And I find it difficult. And now I have to read so many things. I am a book lover also. Actually, cataract was early cataract at 2016. That is why I didn't come here actually. I came here for inspection and all. I am a Tiruvalla and Trivandrum person. So
yes, ma'am.
Studied at Tiruvalla. Actually, cataract was at Caritas Thomas Matthew. And after that, I pray to God, if vision is gone, my mummy's house, Amma's house is retinitis pigmentosa, but nobody in our home. So vision is very important to me. So, and I spend my time for spiritual books and all. And 2020, I think, once bright light at kitchen and all, my daughter-in-law was there. She can see, but I think it is dark. Then I tell. Then again, my husband took me to Caritas. there is a Thomas Matthew, he's a very good, and he actually posterior opacity lens. And laser treatment was done. Before that, 2006 or 2005, it is now about 25 years diabetes, and I am just a bit careless. Then what happened was, accidentally I went to Devi's clinic for another thing, and I tested retinopathy by myself. And there is hypertensive retinopathy and diabetic retinopathy. I'm not remembering, 2006 or something. And afterwards, at Kottayam Medical College, Shoppinameda and all, in between I will go and check. I'm not afraid, but I check. And also Amrita Gopalan was there, his wife is my PG. So 2 or 3 times he also checked. And even Thomas Matthew at 2016, it is not progressing. But posterior opacity, at that time, he said it is increased. I was a bit worried, and Chaitanya only, there is no one at Caritas. So I went to Priya, Shoppinameda advised. And one injection, actually, it is like that. Now it is 4 or 5 months. Before joining here, I had that, and with one injection. So I am actually diabetic retinopathy. Macula is the worst thing. I came home and I like Ophthal, but I am very clumsy with my hands. That's why I didn't take that. And then macular diabetic retinopathy is the worst complication. First sentence, my husband's person was there, and my son scolded me for reading that. Coming back from Chaitanya, that was the first sentence. So I prayed, it should not be like that. And with one injection, I want to check. And Priya said 2 or 3 times we had taken retinal examination, and I will be coming to you also. Mononeuropathy, I didn't understand when first person said, but second person has explained, so I understood that.
Thank you so much, ma'am, for quoting your example.
All over India, I think 50% is not diagnosed, 70% diabetics is not controlled.
Yes.
And it's got all complications. We can see this. I think this all preventable in like setup like in Kerala, where the facilities of the specialist care is very good.
Yes,
Can target nowadays because of the availability of the very good drug, and other things can be meticulously managed. And our hospital has got a very good large team of doctors who can deliver the best care to the patients.
And
we
all
can prevent it.
Sent for diabetic retinopathy screening. We are thankful to all of you for that.
Just one statistic which I remember in our training, which we used to find out, is to emphasize what you said. Type 2 diabetes, you must diagnose at the time of diagnosis, because 20% already have retinopathy at the time. Has the number increased? Just one question. Is it still around 20% at diagnosis of type 2 who have retinopathy?
Yes, sir, that is what I've seen in the last study I checked.
The second question patients often ask us is, now many times we send them to you and they come back to us. So laser veno, is it to give anti-VEGF? If they can afford both, how do you counsel your patients, which is better for proliferative?
Central macular thickness, sir, that we decide.
Okay.
So if it is beyond 400, we advise anti-VEGF, and once the edema is reduced, we would go into laser. So it's based on the central macular thickness.
Yeah.
Jacob, sir, you want to say something? Yes.
Diabetic retinopathy, there is laser treatment is very dangerous. Karnam, rods and cones all are focused there. Chaitanya said, at Chaitanya they said laser treatment cannot be done. Because it is macular diabetic. Macula is the spot where our vision also.
Ma'am, the laser is not done at the fovea. Fovea is the most sensitive part in the retina. Laser is not done at the fovea, it's done slightly away.
I think there's a lot of confusion among non-ophthalmologists about this. If I can just put it in very simple words, there are 2 types of problems taking place in the retina. One is this bleeding that you saw, and the second is edema. Now, if there's a lot of bleeding and that leads to neovascularization, that's when laser, that is pan-retinal photocoagulation. That's a different kind of laser, pan-retinal photocoagulation. When you have diabetic macular edema, that is an indication for the injections, anti-VEGF injections. Along with that, we might choose to do focal laser. The focal laser is totally different from pan-retinal photocoagulation. Pan-retinal photocoagulation is done in the periphery. Focal laser or modified grid laser is done in the macula, sparing the fovea, which is the central area affecting the vision.
Since the fovea is not affected, actually vision is also not affected, ma'am. So, definitely, ma'am. Sir, one is to look for any foveal macular ischemia, sir, and to also find out those small new vessels which we would miss in a normal clinical examination. It will be seen better to also know the type of macular edema like Sandra had shown, whether it is focal or diffuse. So based on that, our treatment would vary. Sir.
Thank you very much, Dr. Leena and team, for enlightening and also presenting a very informative session on diabetic retinopathy as well as diabetic mononeuritis.
Thank you, sir.
What I want to ask is that when diabetics report to you, do you preserve a fundus photograph every time?
Not always, sir. When there is any important findings, for example, like I said, we have a proliferated. We actually have the scenario where we have too many people coming with a normal vision with PDR or with hemorrhages here and there away from the fovea, but their vision is normal. In those cases, we actually take a fundus photo to tell them, see, this is your fundus. But like you said, it is better to keep a photo so that we can show the patient and also keep a record of their fundus findings.
No, I think that fundus photograph is something like an ECG or a chest X-ray, where you can always refer to.
Exactly, sir. We can show the patient also, this is your progress.
Yeah. Thank you.
Thank you so much, sir.
So I have a question especially to the PGs. Just want to understand what are the molecular mechanism behind this, or how do you control in genetic level, if you have any idea? I was just asking, what is the mechanism for this? I mean, diabetes being affecting neuropathy.
Mechanism for diabetic mononeuritis and diabetic retinopathy.
Diabetic mononeuropathy is due to direct damage to nerve cells, and then can be due to ischemia. These two factors cause diabetic mononeuropathy. And then in diabetic retinopathy, due to uncontrolled sugars, the capillary, the blood vessels in the retina, they will be leaking and it will lead to hemorrhages.
The question is, what do you know about genomics in diabetic retinopathy? That's the question. Question is, what do you know in terms of genomics in diabetic retinopathy? Simple question.
I don't know, sir.
Sandhra, you can answer about the other part of the question, the molecular changes that happen.
About microvascular changes, there is the capillary membrane thickening, and there is increased in RBC, there is increased stickiness of platelets, and there is changes in RBC and Role formation and increased viscosity. Changes, that lead to microvascular occlusions, whereas the basement membrane thickening and the loss of pericytes and all, they leads to leakage and edema, which results in retinal edema. The chronic hyperglycemia that advanced glycation end products, polyol pathway are the mechanisms behind that.
Any other questions? Can we wind up the sessions? So I would like to thank every single person who came for our quest. Special thanks to GC sir, Gezia madam, all the HODs, Philip Finney sir, SK Matthew sir. Ma'am, thank you all. JSK sir, thank you so much for spending time with us. Hopefully all the PGs, interns who all have been here, hopefully our quest has been useful to you all. Hopefully you have the take-home message that we gave you. Thank you so much.
Thank you, team of Ophthalmology, for that wonderful presentation by Dr. Jayalakshmi and Dr. Sandhra. And finally, for winding up, Leena ma'am have put forward some brainstorming MCQs. That was wonderful. And I hope in the next few sessions also, if more and more questions are coming up for the PGs, then that will be very useful for them. So that's actually the whole purpose of PG Clinical Club. So thank you so much for all.